important because there's a lot of emphasis on the fact that people with idiopathic Parkinson's disease that don't have genetic causes, because we can rule out all those genetic causes, and the majority, still about 85% of patients who have no known cause. So we're always looking for environmental agents that might be a cause, and I'm not going to get into that. Maybe you can ask me questions about that later. And as I say, it's really the interaction of the two. I remember I was very interested in organochlorine pesticides in Parkinson's disease, and because I had found it in very high levels in the brains of people who had died of Parkinson's, especially one called Dieldrin. But then I did a study, which we never published, where we collected blood from cotton farmers in Clarksville, Mississippi. And we had people, there's a cluster of people with Parkinson's disease, and we got blood from them to analyze for the chemicals that I was interested in. We got blood from people who worked on the same farms, in the same room, that didn't have Parkinson's disease. We made sure they were the same age, and everyone had sky-high levels of this pesticide. So why was it that the individuals with sky-high levels didn't have Parkinson's disease? For me, it meant probably the way it's metabolized, the way it's handled, which is genetically determined, might be the difference. That's why at the beginning I said genetics, environment, interaction. And that's always the case with everything, from everything. It's starting from higher cortical functions and intelligence all the way to simple things like height. Though genetics seems to be very important, kind of environment, the nutrition one has, etc. is all very important. Since I'm running low, here's what I wanted to have 2 slides on surgical treatment because there's not enough time to cover everything. We're trying to give a good overview. But I'll tell you about the kinds of medicines we use now as routine therapy, because all of the more interesting medicines Dr. Hauser is going to be speaking about. So for the very early symptoms, the early stages of the illness, without any disability, I often won't do anything. I might introduce something to delay initiating levodopa. In other words, I know that if I start people on either rasagiline or selegiline, it may have an effect to delay the need for levodopa. If the symptoms are starting to compromise function, I'll introduce a dopamine agonist if someone's less than 60 in general, so a 40-year-old, young onset. I don't want to immediately go with levodopa, so I'll have rasagiline plus a dopamine agonist. So it could be Requib, Mirapex, or bromocriptine. Still useful, but not very often used. The MAOB inhibitors are those 2 I mentioned, rasagiline and selegiline. Those are agents that will likely slow progression of illness, and in fact may be neuroprotective. Dr. Hauser has done some clinical studies on rasagiline as an agent to slow progression, and he'll talk about that, I'm sure. So once the illness has become moderate, and there's symptoms that are interfering with everyday activity, I'll introduce carbidopa levodopa. That's the CDLD, which is really the kind of the gold standard. Nothing works as well as carbidopa levodopa. And I often will keep the other medicines on board. And this is a situation where polypharmacy is useful. It's really hard to keep a person on only one drug for the whole course of the illness because the illness is a constantly changing condition. So you have to adjust medicines. And then when people start wearing off and having motor fluctuations, it becomes very tricky because there you have to adjust the regimen based on the patient's diaries. If they're having dyskinesias, which occur within 3 to 5 years on levodopa, you may need to decrease the total amount of levodopa, decrease the interval, and so forth. I'm not going to talk about the everyday management issues, but many of you know that's the hardest part, is to keeping people on the whole day, preventing them from wearing off, preventing the excessive involuntary movements. And one of the things that happens too is sudden immobility or freezing. And that's a very difficult thing to treat, even with medication. I'm going to skip this part. I have 2 final slides, and we'll finish that in about 3 or 4 minutes. The deep brain stimulation. Generally, deep brain stimulation is brought into play. One starts discussing it with a patient. When a patient begins to develop motor fluctuations. By fluctuations means that the response to levodopa and the other medicines is often very undesirable, and it's characterized by excessive involuntary movements within an hour, or excessive involuntary movements the whole time, followed by off periods, or dyskinesias with off periods, sudden off periods. And those are the complex motor fluctuations. What I do before I even send them for deep brain stimulation is try to have continuous release of an agonist. And so with the Nupro patch, or rotigotine, which was available for a while, I was very happy with the benefits we obtained with it. That should become available again. The other approach I'll use for very meticulous, careful patients is a liquid Cinemet diet, where they prepare their Cinemet every day with vitamin C to prevent it from oxidizing, keep it light tight, and sipping it through the day. It requires a lot of motivation and attention. It's not for everyone, but people with severe motor fluctuations will do well with that for a while. But eventually, they may come to a discussion about deep brain stimulation. And what it involves is really three components. The mechanical part of it. I'll talk about the mechanical part first. One is this lead, which is placed down deep in the brain. This is thalamus, but usually it's put down in the subthalamic nucleus. There's the electrode, the lead, and then there's this extension that goes under the skin here, under the scalp, connects to a pulse generator and a battery. The target that is used most commonly for complex motor fluctuations is now the substantia, the subthalamic nucleus. So what you can see is that this electrode is lowered down with MR guidance, and then to make sure it's in the right place, there's recordings of electrical activity of those neurons. They have a certain signature when they're in the subthalamic nucleus, certain frequency of discharge. And then the patient's also conscious and is asked to move. And so they stimulate this electrode at different frequencies and find the target and the right frequency that attenuates or improves the speed of movement, attenuates the tremor. Usually it's a finger tapping speed is what they'll do. And so that's the site and the mechanical and aspect of it. The way that this is done, I usually will spend more time with this, but it's an MRI has to be done before, a halo is put on, and before the MRI to help them really navigate to the exact site. Now, after this is done, there's a lot of adjustments of the stimulating frequency, voltage, and so forth that are done in the doctor's office by an experienced, usually a nurse coordinator, or sometimes it's a neurologist, who is experienced with the parameters of deep brain stimulation. And most people who have DBS still need to take medications. Some patients are certainly able to decrease their total dosage of levodopa and medication. The amount of reduction varies from patient to patient. I recently saw a person who had gone from a maximum of 24 tablets of Cinemet a day, and that was on his own because we never wanted him to do that. He had the worst dyskinesias in the world. He had deep brain stimulation, was able to get back to 1,200 milligrams of levodopa, 12 tablets a day, still had a lot of dyskinesias. And when I last saw him, he was finally persuaded to stop the Cinemet for a while and only have the deep brain stimulation. And he was incredible. He had no dyskinesias. He was walking. He didn't have tremor. So every now and then you get some really amazingly good results. The only problem I have with this procedure is it doesn't really improve gait and balance. It doesn't really improve sudden immobility or freezing. And sometimes it can affect speech, especially if you have both sides put in. So I'm going to summarize and end here. The Parkinson syndrome has many causes, both the genetic and environmental. However, Parkinson's disease, the loss of dopamine neurons is only one component of the disease. the underlying pathology is much more disseminated, involving the whole brain, and even muscle and other parts of the nervous system outside the brain. The replacement of dopamine is what we do best, and it results in an excellent control of motor movement for a while. And in some patients, for the rest of their illness, they do really well. About a third of the patients don't have all of these complications. The other two-thirds tend to have some kinds of complications, even if it's complex motor fluctuations and so forth. The brain stimulation is used for those that have complex motor fluctuations. Although I think Dr. Hauser is going to speak about novel medications that would be used for very serious dyskinesias. And I think that's the way to go. As neurologists and pharmacologists, we'd rather not send our patients to have a surgical procedure. Surgical procedures have been very useful for many patients. And the major thrust of research right now is to find a way to slow the progression of the disease by modulating the underlying pathological processes. So I'll end here.